Whole genome sequencing at birth. What should be looked for? What should be fed back? The hashtag for this event is Genomics Conversation, and this discussion event has been made possible thanks to Genomics England. Now, Genomics England was set up back in 2013 to deliver the 100,000 Genomes project, and this flagship project's aim was to sequence 100,000 genomes from NHS patients with rare diseases and their families as well, and also patients with common cancers. Now, call it a coincidence, call it serendipity, but in this week's BioNews, we covered two lots of research that have come out of that project. The 100,000 Genomes Project pilot on rare disease diagnosis in healthcare, their preliminary report was published just last week and showed that rare disease diagnosis is improved by whole genome sequencing. And there was a case which typified the value of whole genome sequencing in healthcare, which was the genomic analysis of a baby boy who died aged 4 months, and the analysis found that his health problems were caused by a genetic variant that caused the faulty transport of vitamin B12 into his cells. And by identifying the underlying cause of death, doctors were able to test his younger brother at birth and subsequently establish a program of weekly vitamin B12 injections. And this halted his disease progression. The other study which came out of the project last week was one in which researchers had shown that whole genome sequencing of children with cancer can improve both the accuracy of their diagnosis and also better inform treatment options. And although it was only a small scale study, the results demonstrate that the capabilities of whole genome sequencing in this field, which is good because it's set to be rolled out across England as the standard care for all children with cancer. And tonight we are here to discuss Genomic England's Newborn Genomes Programme. Now, the screening of newborns for disease has been performed in the UK since the mid-1960s using heel pricks, blood spots, and a small number of conditions can be screened for under the present system. And our most recent event discussed the issues and concerns around the current system. Genomics England's Newborn Genomes Programme will explore whether and how whole genome sequencing might in future be offered routinely for newborn babies in the UK. And PET is really thrilled to be producing a series of 5 events covering different topics relating to this project to help shape the programme, we hope, tackling some of the special sensitivities that a project of this magnitude may give rise to. And tonight's experts and advocates will discuss which genes and variants in the genomes of newborns might be studied and reported on. And there's a whole range of questions that we've been thinking about at PET in relation to this. For example, what shouldn't be included on a list of genes and variants to be studied in newborns? And just as importantly, by whom should this be decided? And are there clear principles that can be cited or established to guide the content of such a list and the way the list is used? And I think another important question is how to best ensure that there's thoroughgoing consultation and ongoing engagement with appropriate groups and stakeholders on the content of such a list. Should such a list be dynamic? And if so, how often should it be reviewed and updated? What, if any, lessons can be learnt from the work and experiences of other organisations which already maintain lists of genes and conditions? Because it's always good to see what you can learn from others, whether it's mistakes they've made or when things have gone really well. And one of the things we were thinking about as well was, should more than one list be maintained? For example, it might be one list for clinical purposes, so for cases where measures such as penetrance and actionability meet a certain threshold or criteria, and a separate list of variants or conditions for which there are relevant close to market therapies or perhaps very promising research in the pipeline. And if we were to have that sort of two lists of the dual system, how would that work in practice? I'm in the lucky position that I don't have to answer those questions, but I'm thrilled that we have a fabulous lineup for you this evening to discuss what should be looked for and what should be fed back. So we have Dr. Richard Scott, Dr. Charles Steward, Professor Francis Flinter, and Dr. Emma Baple. Richard is Chief Medical Officer at Genomics England and Consultant and Honorary Assistant Professor at Great Ormond Street Hospital for Children and at University College London's Institute of Child Health.
As you've heard from Sarah, we at Genomics England have been working to think with PET how we can engage on some of the really important topics that we want to and have begun to explore, thinking about the potential benefits and the research questions and questions of important public interest that we need to explore around whole genome sequencing in newborns. And this is the first of those events. As you've heard, the focus today is particularly on thinking about how one might make decisions around which genes one focuses on, which regions of the genome, and what would be fed back. I wanted to start by stepping back a bit, if that's all right, to frame where we are in our thinking, to give you an idea of what discussions we've had, discussions we've started, and those that we think are particularly crucial to engage in early in this process. I'm going to do that. Also, to let you know, Emma, who is our fourth speaker today, is going to talk about some of the work that we've been doing with her and an NHS steering group that we've established to start some of the specific conversations on this topic around selections of regions of the genome. So I hope our two talks, which will bookend the talk component of this evening, will work nicely together. I'm going to share my screen and just walk you through some slides to frame where we are and give you a feel of where we are in this process. So we've been at Genomics England, as you've heard from Sarah, thinking about genomics and genomics examining the germline and looking at rare diseases since the outset of the 100,000 Genomes Project and when we were first established as an organization. We've been thinking hard about the potential for whole genome sequencing in newborn babies for the last 3 or 4 years and working with experts and with the public and participants in our programs. And most recently, this last year, as I'll talk to you about over the next few slides, we've been doing a couple of things. We've had a formal public dialogue, which we commissioned jointly with the National Screening Committee, with 130 members of the public to explore some of the public attitudes to whole genome sequencing in newborns. And we've also formed that NHS steering committee with a variety of experts and participants in various areas engaged. And what we've done through that and with this NHS steering group is to develop a vision for where we think we are, whether we think the important questions are. So we are keen to explore the benefits and the challenges and practicalities of offering whole genome sequencing in newborns. We recognize two things I think are really important here. Firstly, that there is the importance here is developing evidence to inform future potential NHS commissioning decisions. This is not a case where we feel there is already all of the evidence available, and it's very clear that the questions need here to be explored in an ethics approved research pilot, very clearly with that framing and very clearly focused on questions that we need to evaluate so that we can inform future decisions. What's also crucial is that we do this together with both the public, but also people who will be delivering this research program and also a potential service in the future. So that co-production is absolutely central. And this needs to be done in the context of the real everyday NHS, both so that we can think about what would really work in practice, but also so that if it were to be something that showed value and was adopted, we'd have learned those lessons. We'd have understood what the impact is on day-to-day care, on workforce, what we need to do to make sure that it would work. And to make sure that everything we do is really focused in the reality of day-to-day, recognizing the needs to both approach the sort of design of a potential service from a human-centered perspective, and also the ethical framework that we need to take when we're designing such a service. We're thinking of the questions that we're exploring in 3 distinct groupings, and I think it is important, we think it is important to think of them distinctly. They obviously overlap, but they are distinct. The first is the potential for whole genome sequencing to do what Sarah described, to try to identify conditions that are potentially quite like those 9 conditions we currently screen for in the heel prick, where one can identify potentially with whole genome a high likelihood of a baby developing a severe condition for which there is something treatable that we could intervene with. So that's component 1. We'll come back to that. Component 2 is to support and enable research into new treatments for patients, potentially also new biomarkers to identify potential new avenues, that potentially things that could feed into that first component. But as Sarah highlighted, a distinct question, and potentially something that participants and people joining the programme might think about quite differently. And thirdly, to explore the potential of a genome being part of your medical set of data that could be used at different stages of your life for different purposes. We think each of those 3 streams are things that we need to explore as part of this programme. We also think they might be explored at different paces during the programme, with the first one being the one that we think we will explore at the greatest pace. One of the questions we often get is why whole genome sequencing? And I think that's worth pausing on a little. And I think, again, Sarah has alluded to some of these things already. So there's great value in genomic testing of various sorts in potentially identifying particular rare disorders. Some of the advantages we see, including in the New England Journal article published last week, we can see, for example, coverage of parts of the genome that aren't covered by other technologies, or types of variants that aren't easily detected. There's also great benefit in terms of the flexibility. For example, being able to respond to new regions becoming either identified or felt to be important to analyze. For example, if one discovered another cause of one of the important conditions that people wanted us to feed findings back on, you could rapidly respond and include that in your analysis. That links, I think, to future-proofness. No technology is future-proof, but it allows more potential for future uses to be adapted. And also allows, and particularly linking to that second area of exploration, that potentially is really important in supporting discovery not just of other regions that might be important in causing disease, but potentially also modifying response to treatments and so on. And then finally, there's that lifetime potential piece, where the genome could be a resource for multiple different uses at different stages of life when that's relevant. Very briefly, I think to emphasize, we're early in this process. We've worked, as I said, with this newly formed NHS steering group, and at the end I'll show you a screenshot of the membership to give you a feel of the sorts of expertise that we have there from across the spectrum. And we're just beginning to enter this co-design and feasibility stage. And that's why we want to engage through PET, but through other avenues, to really engage with experts, with the public on these sorts of questions, so that we make sure that we get this right. That will feed into a design of this research pilot that we think is necessary before one could consider adoption into mainstream care. That research pilot we're looking at, we think, to develop the evidence one would need, it needs to be sizable, certainly we think would need to be 100,000 babies, maybe, and up to 200,000. And that research pilot we would see as developing evidence that could then be reviewed to consider whether or not this is something that should be adopted. We think that research pilot is something that is necessary. We also think that we have at least 18 months before that it would be right for that to start. And during that process, one of the important questions is to constantly sense check on whether we have the right information, we have the right designs, we pass through sort of go, no-go steps, and to be careful, because we need to do this right if we're going to do it. I think a really important thing that we've heard from a lot of our stakeholders is that the UK is really well placed to do this, both because of the NHS being a single payer healthcare system, but also because of the size of the country and the infrastructure and genomics know-how that we have. We're really well placed to develop evidence that other places in the world are less well placed to develop. So I've talked about the collaborative approach that we're engaging in. We've already had a formal public dialogue. We've formed an NHS steering group, and we're engaging increasingly with specialists and experts. And we're beginning to see some themes emerge. We've been discussing with the groups, we've engaged with the benefits and the limitations, the unknowns, and we think it's really important throughout this always to be really honest and clear about the limitations of what we can and can't do. And we need to go in with our eyes open to those. And we believe passionately that in that context, there are really important questions to answer. We'll hear today a bit from me, but more from Emma about how we're thinking about the development of principles around how you might select conditions to be included. And we think that development of those principles, real transparency on how we do that is really important to get this right. To get the approach to patient information, participant engagement, so that people know what it is that we're considering offering in terms of a research programme, what they're signing up to, what they would expect if genomic data were used now or in the future, and to be really inclusive so that this is something that it would be relevant to all families and accessible. To build on much of the work we've done over the years in making sure that the way in which the data is stored is safe, is one which the participants in our programme would trust, and that we maintain that trust. And finally, the importance of really recognising that the NHS is a busy healthcare system that is stretched always, and this part of our research needs to establish how a programme like this could be delivered in that context, and what, for example, extra workforce considerations would need to be factored in. So where do we start? Just a brief introduction to some of the pieces of information and collateral that we've been really leveraging as we've been beginning this exploration of how we might ask this question. What conditions might we look at really early in life to identify, so that we can feed something back to a baby in the newborn period? I think one thing just to frame, so that people perhaps who are less familiar with some of the terminology, is quite useful here. When we generate whole genome sequence data, it's 3 billion letters of DNA code. It's very complex to look at. A human can't just look at it and interpret stuff. Always you use bioinformatic algorithms to process it. That's a challenge, but it also gives you a choice. It gives you the power to decide what you look at, what you want from that data to be reported back. So we have this concept of applying what we call virtual panels and saying, I want to interrogate the genome for these questions, because this is what is right for this participant in this program at this time based on today's evidence. So it gives you that power to do that, but also to, in the future, ask different questions if that becomes the right question. So when we talk about a virtual panel, that's what we're talking about. So we've got three what we thought were particularly interesting inputs that we just wanted to share with you, that have been really important in founding some of the discussions that Emma will talk in more detail about. So firstly, the public dialogue we jointly embarked on with the National Screening Committee, which asked about public attitudes to whole genome sequencing in newborns. And we got, as you'd expect, a diversity of views. This was not homogenous, but there was real interest in us exploring this. And I think a real clear message of, we think this is right to explore. We need you to explore it carefully, and please do it right. Do it in the right way. And that, I think, will be really important as we go forward to recognise that diversity of views in the context of general public enthusiasm for us to explore this. The second, and again, Sarah alluded to an event recently at PET, talking about some of the views on newborn screening more generally. We've read with great interest the Genetic Alliance report from 2019. And again, there's enthusiasm from Genetic Alliance, who are a community principally around patients and families who've suffered from rare disease themselves, about us exploring this. Another thing that is important to acknowledge is that it's also really important for us to take in the views of people from the public who haven't had exposure to rare disease, because their opinions are often different. So again, importance of taking in the diversity of views and factoring that in as we think. And finally, this is a paper that we wrote over the period of a couple of years, beginning some of the thoughts about how you might begin to develop a catalogue of conditions that you might think about being relevant and feeding back in the newborn period. What we did was begin to compile a long list of conditions that one might use and look through. But there's then a lot of work to work through questions of the thresholds of confidence that people would expect before you wanted to feed something back to a family, this issue of penetrance. How likely a particular variant is to actually predict disease happening. What's your definition of something being actionable? What do people actually want to hear about? What level of evidence of a treatment being effective, or what degree of impact would you expect before people want that to be included in something that would be fed back? Lots of these questions aren't new. They're the sorts of questions that, for example, having the National Screening Committee as part of our NHS steering group in our conversations is really important, because many of these aren't new questions, but it's about thinking about them in this new context that's really important and shows enormous potential for whole genome sequencing, helping in that newborn period. And finally, I just wanted to highlight that this is just one of a large number of different areas that we're really keen to explore. There's lots of questions, and these will be explored over the coming events about patient choice and how comfortable people are in engaging with a program, about the broader societal impact of a program like this, about the long-term viability, and some of the questions of feasibility. And those are questions that I think we'll focus less on today and more on in the coming events and in our other engagements. But just to acknowledge, this is just one of a good number of really interesting and knotty topics that we really need to engage on to make sure that we get this right. So I wanted to close by saying thank you. Thanks for joining us this evening. Thanks for being part of this conversation to help us have these discussions really in depth and to challenge our thinking at every stage. I'm going to close actually by just showing you a slide to give you an idea of some of the people who are on our NHS steering group who have been really important in developing our vision to this stage. And I really look forward to hearing the other talks this evening and to being part of the Q&A at the end.
And I'll introduce our next speaker this evening, who is Dr. Charles Steward. And Charlie is lead for patient advocacy and engagement at Congenica and advisor to numerous patient, clinical and scientific organisations. And he is the parent of 2 children with severe neurological disorders and who have both participated in the 100,000 Genomes project. Now, Charlie can't be with us this evening because of his family situation, but he has done a pre-record for us, and he is he is hoping to join us for the Q&A, circumstances permitting. The heel prick test, did that help detect the condition that affects your children?
No, it didn't. And in fact, as has been mentioned, my family, we've been through numerous genome studies in the United Kingdom, and in fact, the condition has not been found in the genome yet. Now, of course, that doesn't mean that their disorders are not caused by genome defects. Rather, it could be that we just haven't found them yet. So no, the heel prick test hasn't helped in that regard. I suspect that their condition is genetic. They both have the same type of cerebral palsy. My daughter had epilepsy as well. And I suspect that the cause is likely to be something to do with preterm birth. I suspect it may well have its origins in something like a collagen gene or something similar structural, because both births were a result of a placental abruption. And I suspect that looking at the family history of both me and my wife, there are smoking guns, should I say, that are suggestive of something to do with a collagen type problem. If we found out what the genetic cause was, it would probably mean that it would impact on our lives, later lives. If you're talking about a structural protein that's involved in blood clotting, knowing the cause may well be helpful to understand how, what sort of measures you could potentially take in your life. As you know, I'm involved in various different groups, and one of those groups I'm involved with is the International Cerebral Palsy Genomics Consortium. And it's interesting, when you talk to people about cerebral palsy, everyone is of the same persuasion that, this is just a sad, unfortunate event that happened at birth. And in fact, there is sort of a precedent for this type of thinking. If you go back to look at the original sort of origins of research into epilepsy, back in 1975, people thought epilepsy was just, it was an idiopathic cause, which really means that it's unknown. And it was a clinicians gave this diagnosis to reassure patients that they've been given a diagnosis. But of course, the more you look into epilepsy, the more you realize that there are significant genomic drivers there. And particularly sort of a young onset epilepsies, we're getting diagnostic yield of around 50%. And it's the same with cerebral palsy. Cerebral palsy isn't just an accident at birth. Anything between 25 to 40% of children who are diagnosed with cerebral palsy are misdiagnosed with potentially something like leukodystrophy. And of course, leukodystrophies are just the most terrible, terrible disorders. And some of them, they can come on quite relatively late in childhood life. And so, your child develops normally up until sort of however old, 6, 7, 8 maybe, and then they begin to deteriorate. And there are a number of these different types of leukodystrophies that we're beginning to see that if you intervene really swiftly, that it's possible to stop these neurodegenerative symptoms from occurring. So stem cell therapies and gene therapies appear to be probably the most promising in treating leukodystrophies, providing it's done as early as possible. So this comes back to the whole idea of newborn screening. And if you can pick these sorts of disorders up quickly and intervene quickly, you can prevent many of these terrible symptoms occurring. And it's the same with epilepsy. So if you get in there quickly, you can intervene with the child. And that's also what happened with my daughter, who had something called West syndrome or infantile spasms. The actual spasms themselves, the seizures themselves, are believed to cause brain damage. It's not quite brain damage, but that's an easy way to sort of understand it. And if you don't get control of the seizures, then unfortunately the child regresses until obviously very bad outcomes. And luckily for me and my wife, our daughter responded very, very quickly to a clinical trial within 24 hours. And she started to develop again. She'd been regressing in the development. And the quick intervention means that she still has lots of troubles. She hasn't developed as a normal child, but she has got a much better quality of life than she would have done. So newborn screening, quick intervention, already we can see the possibilities. There is a perception that newborn screening can be used for nefarious purposes rather than actually intervening to help patients in their lives and their later lives, understanding the sorts of conditions they might get when they're older, or conditions that they have that they're born with. And I think that it's absolutely essential to engage the public, to engage parents around the sorts of things that they would like to know. The parents, the patients, the carers should really be at the centre of anything that occurs. And I say this often, but the parents of children with disabilities or rare diseases or patients themselves, they are often the world leading experts in their fields. I mean, they will be lay people mostly, but they will have the inspiration to go and read everything about their disorder. I've met some paediatric neurologists in my time, and they're the most extraordinary, brilliant people. They truly are. But even they would say that, they have to learn 700, 800, 900, I don't know, pick a number, however, many different disorders. And there's no way that they can know them in the detail that each parent does about their own individual disorder. So I think it's essential to listen to parents. I think it's essential to listen to any concern that they have. I'm thinking of a particular example of this year where a friend's daughter had a severe intractable seizures. She was very young and went on a genome study. He had reached out to the community, the epilepsy community, and someone in Canada had reached back to him and said, the picture of your daughter is striking, identical to my child who has been given a diagnosis in a specific gene. And he went back to his clinician and said, can you please check this? Can you check this gene? They said, no, there's no point because it's not expressed. There's no publications to say that it's expressed in brain, only in heart. His daughter died this year, and a week before she died, he had a son that was born who went on to develop the same seizures. Pleading with his clinicians to check this gene, absolutely, he was spot on. The clinician said that he was probably the first time they've ever met a parent who diagnosed their child's disorder. Now, that of course doesn't mean that it's not going to affect necessarily the treatment for his child, but certainly it would have been useful to have known. I have to be careful with that because that you couldn't make a clinical diagnosis just based upon that information. That you have to do much more. But this is a great example of a parent really having the intuition and the understanding and knowledge around a specific disorder.
The obvious question is what should and what shouldn't be included on the list of genes and variants that should be studied in newborns?
If you take the 100,000 genomes, and if you look at, I don't know what the numbers are, but there will be a group of people who just want to get a diagnosis. There will also be another group of people who want to get a diagnosis and perhaps know a little bit more about their genome. And there'll be other people who are just so carefree, they want to know absolutely everything that there is to know. For me, for my family, and we've talked about this at length actually in my family, we would really only want to know things that we can actually act upon.
My understanding is that a list will be generated at the beginning of this. Do you think such a list should be dynamic, and how often should it be reviewed and updated?
Perhaps you could have sort of lists where you've got a solid set of genes where that you can do something about, and then perhaps an expanded list of those where there are currently clinical trials going on. It can only encourage people to look into more therapies if they know that their close to market therapy is going to be included on a Genomics England panel. It's an encouragement for them to work harder to get something developed, and it just offers up so many more avenues of treatments. And I'm sure that different therapies can be only used on different disorders, but I'm sure there are lessons to be learned from one disorder to another with therapies. And this just is it's the opportunity to make a really, really nice resource, for researchers, clinicians, and also for the patients.
So next up this evening, we have Professor Frances Flinter. Frances is Emeritus Professor of Clinical Genetics at King's College London. She's also a member of the Nuffield Council on Bioethics, and by far the most important role she has, she's a trustee at PET.
So we heard in the excellent PET discussion 2 weeks ago how spots of blood are collected from newborn babies by pricking the heel to find out whether the baby has one of 9 rare but serious conditions, such as cystic fibrosis, congenital hypothyroidism, phenylketonuria. And babies who test positive can be treated early, improving their health and in some cases preventing severe disability or even death. And tests are done for serious conditions for which there is benefit from making a diagnosis early in childhood. You've heard the phrase actionable results. We don't test for adult onset disorders, and the aim is only to offer tests for which the results should be clear. So why might we want to screen for more? Well, first of all, to benefit the child, as you've heard, to identify asymptomatic children who would benefit from early therapy. And a very powerful example was given 2 weeks ago, discussing the benefits of offering gene therapy to children with spinal muscular atrophy. And it was very clear the sooner they're treated, the more they benefit from that treatment. The other key driver to expand neonatal screening is to avoid a prolonged, what's sometimes referred to as a diagnostic odyssey later on in life once a child becomes symptomatic. Some children, as the family we've just heard being described, have obvious symptoms, but despite numerous investigations, a diagnosis cannot be found. However, the development of whole genome sequencing in a diagnostic capacity means that once a child becomes symptomatic, diagnostic testing should be much quicker. And the publication that Sarah mentioned earlier in the New England Journal of Medicine showed how 25% of participants in the pilot part of the 100,000 Genome Project got a diagnosis, in many cases after waiting years in order to get one. The other reason that people might consider expanding neonatal screening is to benefit others. It would be possible to identify conditions that might affect future siblings. There may be no early treatment available for the child in whom the diagnosis is made, but parents could be alerted to the risk in future pregnancies. And collecting large amounts of genomic sequence would also enable the creation of large genetic databases that can be used for research to develop new tests and treatments. So if we think first of all about what we could test for using whole genome sequencing, well, the answer is simply any genetic alteration in the DNA. That could include single gene disorders such as polycystic kidney disease. It could include susceptibility to late onset disorders such as Alzheimer's disease. It could include screening for polygenic abnormalities that shift the risk very slightly in terms of someone's likelihood of developing coronary artery disease, for example, later on in life. Although in fact, environment and lifestyle often have a much greater impact on an individual's susceptibility to those sorts of conditions than their particular cluster of genetic alterations. And we could, although I'm certainly not suggesting we should, screen DNA to identify markers that might suggest increased sporting or musical ability. And I think it's very important to remember that interpreting results in asymptomatic people is more difficult and may be misleading. And I'd like to read to you a statement from the Academy of Royal Medical Colleges on genomic screening. They're the umbrella group for all the Royal Medical Colleges, and they issued this statement 2 years ago. They said, many people who are genetically predisposed to a condition will never develop symptoms. Despite extensive research, the full consequence of most variants when found in a healthy person is not known. Before variants are used in screening tests, information about the likelihood of disease developing when the variant is found in a healthy person and its clinical relevance must be available together with data on whether the proposed test meets the current NHS requirements for screening. Failure to adhere to these principles may expose people to unnecessary risk and the NHS to considerable unnecessary expense and resource utilisation. So bearing that in mind, what should we test for? using whole genome sequencing. And I think there are two key criteria that emerge. Firstly, diseases where early diagnosis and treatment makes a difference, especially if the intervention prior to the development of symptoms is helpful, and diseases for which other methods of testing are less sensitive or less accurate or take significantly longer. What are the risks of neonatal whole genome sequencing? Well, first of all, there's a very practical issue. The workforce in the NHS lacks the time and knowledge at the moment to counsel parents on the options. I heard recently from an obstetrician that there's more than 100 pieces of information given to a woman in the antenatal booking clinic. And if, in addition to all of that, it was necessary to have a discussion about all the pros and cons of whole genome sequencing, you could see how this would quickly become unmanageable. There's a particular risk of unclear or uninterpretable results, and especially in ethnic minorities, because we know less about their DNA sequence, as fewer have been enrolled in previous whole genome sequence studies. There is a risk of causing unnecessary worry. For some metabolic conditions, up to 90% of apparently positive results may actually be false positive results. And yet, if all those children are referred to specialist clinics, this could overwhelm the services and compromise what is available for children who are genuinely affected. There's also a risk of false negatives. We know that tandem mass spectrometry is better at diagnosing some metabolic conditions than whole genome sequencing. There is a concern that there may not be clinics to refer children who have screened positive but who are currently asymptomatic, because paediatricians will want to focus their limited resources on children who currently have symptoms and need treatment. There's a risk of damaging the parent-child relationship or of disrupting that important period of bonding in the neonatal period. And it could be very awkward if inadvertently non-paternity is discovered at that particular point in time. And we need to remember that information may have implications for relatives as well. Who's going to be responsible for managing that? I think there are a few other important questions that we may wish to discuss today. Who should have access to the sequence data? How long should it be stored? The DNA sequence won't change, but the quality of sequencing and our ability to interpret it is bound to continue improving. How do we protect the child's right not to know about their genomic makeup? Should we report uninterpretable results? What else might people want to know? And can parents choose to have their child tested, but then opt out of their child's sequence data being shared? So in conclusion, I'm aware that whole genome sequencing is an extremely exciting development, and its use for making a diagnosis in previously undiagnosed symptomatic children is well established and very powerful. The evolution of faster diagnostic turnaround times when testing is offered to symptomatic children, I think, will to some extent negate indications for neonatal screening, apart from a few exceptions where treatment is indicated prior to the development of symptoms and other screening tests are less effective. The value of whole genome sequencing in apparently healthy neonates is unknown, and that's why it is entirely appropriate that any pilot project is clearly badged as a research initiative which needs to answer this question. But it will take years to collect all the data, and particularly to understand some of the implications of children who are diagnosed as apparently affected conditions, but may only many years later be confidently cleared of that particular diagnosis. And all participants in this sort of project must understand the risks as well as the benefits. So while I think a strong case can be made for other conditions to be added to the list of diseases for which newborn screening is beneficial, whole genome sequencing may not be the best technology to use in every case. And I think it's important that developments should be driven by clinical need and the identification of the best test for each disease nominated, rather than by technological developments.
Now, finally, this evening, we have Dr. Emma Baple. Emma is a consultant clinical geneticist at the Royal Devon and Exeter Hospital, and she is clinical senior lecturer in genomic medicine and medical lead for rare disease in the Southwest Genomic Laboratory Hub. And Emma is co-chair of the Rare Disease Test Evaluation Working Group and a member of the NHS Newborn Screening Group.
So I'm going to lead on from what Richard was talking about earlier. I'm going to talk a bit more about developing a conditions framework. So how do we decide what conditions we should look at through whole genome sequencing? And I was asked to chair the working group that's going to look at the principles that guide that. So I think probably the most important thing for me to mention on this slide, following on from what Francis said, is to say we should acknowledge that there is anxiety and concern about elements of this. And that's because of this point here on the left-hand side of my slide, which says we need to balance what we should do with what we can do. And that's why these guiding principles are really important. So co-developed comes at the top there. That means that we absolutely need to engage patient and public groups in this process, as well as the clinical, scientific and ethical experts. And that's because we need to be absolutely certain that we're confident in the validation of this framework. It needs to be transparent. We need to be open about the rationale that's been taken around decisions, why certain things have been included, and there needs to be a lot of time given for consultation around that, for people to talk about their concerns, or indeed to say why they think a condition ought to be included. Absolutely everything that we do needs to be evidence-based. It needs to be informed by robust evidence, and we need to achieve a balance between those clinical, scientific and ethical aims. It needs to be flexible, so the advantage that we have from whole genome sequencing is that it's flexible. As new evidence emerges through research, we need to make sure there's that flexibility of adding in new genes, and that is something that whole genome sequencing does give us. So I wanted to come back to what Richard mentioned earlier and talk about whole genome sequencing and gene panel analysis. I think it causes a lot of confusion, even amongst doctors that request these tests. So we sequence the whole genome, but we're only talking about looking at a desired panel of a virtual panel of genes. So we're only looking at that virtual panel of genes. And that's what this framework is about, thinking about what genes within the genome we look at and what genes we think about returning results from. So how and what should we be thinking about in terms of the principles for what disease types we should look at in newborns? Essentially, the focus of this work is to look at those principles and the criteria of for which disease types the newborn genome sequencing pilot should be looking at. Those principles will let us design a framework, and they will allow us to build in the disease types as the right evidence is available. It's essential to ensure those principles are validated, as I said, with the right level of scientific and public input to make sure it's scientifically valid, publicly and ethically acceptable. And we have other existing services in the NHS that this needs to link into. So for example, in Exeter, we have a rapid exome sequencing service for babies and children who are acutely unwell, thought to have a genetic disorder on intensive care, and for whom a rapid diagnosis in under 2 weeks, actually within about 9 days now, can change their management. So that allows us to link this program into that existing program. I want to talk a little bit more about the details now. So how do we actually get into the nuts and bolts of developing a framework for including conditions and genes and variants? These two questions on the side here are the two that I think we should be most focusing on initially. So what is the clinical utility for each vet condition or gene change that we're looking at? So when we're talking about utility, we're basically saying, how helpful is this? Are we going to get helpful information about diagnosis, about treatment, about management, about screening? And then a term that I think is quite difficult for people to understand, including myself sometimes, what's the clinical validity for each condition or variant? So in other words, how reliable is it? How reliable is the test? Does it define the presence and the absence of the disease accurately? So I'm going to come on and talk about some of the more tricky questions that we need to think about. What is an acceptable level of confidence? How confident should we be in that result? Is it, if you've got a life-saving treatment for some, should you prioritize that over uncertainty for others? What makes a condition actionable? So, for example, is a condition actionable if there's screening in place for a disorder that might prevent something from a person from getting ill going forward? Is treatment and or support available in the UK for a disorder? So if there's a treatment, that's great, but can we actually give that treatment to people? What is a treatment? Is a treatment something that treats the underlying pathology of a disorder? Or, for example, should we be thinking about treatments that perhaps don't necessarily treat that underlying pathology, but certainly help in the outcome for that patient, for example, hearing loss and cochlear implants? When we're defining the age, when we're saying it's affecting in early childhood, what do we mean by that? What's the maximum age of onset of first symptoms? How common is a condition? Does it matter how common it is if we've got whole genome sequencing and we're using the same test? How variable are the clinical features and outcomes? How much confidence can you have when you're telling a parent about that disorder? What features of their child, what problems is their child going to develop? What age are they going to get them? What would that look like? These are not easy questions. So these are our core principles. Who benefits? When should we be doing it? And what action? So the proposed approach currently is who benefits? Well, the baby, the child. But you could put arguments across, and people have, for parents and the wider family. The benefits of society. I talked before about when should it be the newborn period? Should it be early childhood? What is early childhood? And what action? Is it treatment? How are we defining treatment? I never ever want to tell a parent of a child who has a disorder that their child's disorder is untreatable, because there are always things that can help with management of a condition. But when we're thinking about treatment in terms of newborn screening, are we talking about curative treatments? What are we actually talking about? You can think about clinical follow-up, surveillance, as I said, reproductive choice for parents, information. So building on that further, I said, should the beneficiary be limited to only the baby? I think that's something that I'm expecting to have questions on. I do think it is difficult to define the age of onset. I do think it's difficult to think about what is actionable. It can be hard to get evidence in rare disease for treatments. So what level of evidence do we need to require for a treatment to be considered proven versus experimental? This is a really busy slide, but I'm hoping it helps you to visualize some of the principles and the grey areas that we really need to get into and consider when we're thinking about this. So these numbers that are on this slide come from a published resource of genes that are associated with treatable disorders. But treatable in this sense has been considered addressing the underlying disease pathology. So diet, supplement, enzyme replacement, gene therapy, surgical procedures, things that are addressing the underlying thing that's gone wrong in the body. Then if we go deeper in there, we can think about things that are substantially reversible in terms of early childhood. And those then that are completely penetrant in early childhood. So we've got a couple of disorders there that I think there wouldn't be a huge amount of arguments about including in a newborn screening program, because we have a treatment, we know it's substantially reversible, and we know it's we know that there's high penetrance. So for example, the form of eye disease that I've put there, that form of retinal dystrophy, there's a treatment that can prevent visual loss. Congenital adrenal hyperplasia, there's a treatment that can prevent a life-threatening event in childhood, a salt wasting crisis. But there are lots of grey areas in here. So as I said, is it helpful to be thinking about disorders where perhaps there is a treatment, but it doesn't necessarily substantially reverse the disease? Is it helpful to be thinking about disorders that are perhaps more variable in their onset, but there is a treatment that could be life-saving? None of these are easy questions to answer. And the more we relax our thought processes, the more disorders that we would have to consider and the more that complexity builds and builds. This is just a starting point, and there aren't any easy answers. But at this point, the most important thing we need in place is to ensure that we've got the right people and the right expertise involved in discussing this and involved in the conversation, so that we can consider this pilot and that the pilot is well thought out and safely done, and that the list of disorders that we're thinking about is well considered. I'm expecting that there'll be lots of questions about individual diseases, both whether we include those diseases or whether we shouldn't include those diseases. And people's personal experiences always come into play when we're thinking about those sorts of things. There's a lot of people who've put an argument across for the diagnostic odyssey, reducing the diagnostic odyssey, as Francis mentioned. But that's got to be balanced against taking away a healthy child from a parent, or what they perceive to be a healthy child from their parent in that early stage of life, when they're bonding with that child and they don't know that their child's got that disorder. So these questions are difficult to answer, and people's perception and views on those depend on what their experiences are in their life and where they've come from. But that's why it's important that we have everybody involved in this discussion: patients, the public, clinicians from all walks of life. And we are being challenged on each of these elements, each step of the way, so that we get this absolutely right. It's a really, really important opportunity in England to do this and to do it right. But we need to be challenging and asking questions all the way.
So I'm going to go with a question from William Owen, who's asked several questions and made quite a few comments actually. And he says, how does the genomic approach sit with current PHE screening criteria as interpreted by the NSC? So that's Public Health England, for sort of to unpick some of the acronyms, and interpreted by the National Screening Committee. So perhaps if we go to Rich first with that, and then we'll see if others need to pick up.
So I think what's really interesting, and I think you will have picked up particularly from Francis's talk, in many ways whole genome sequencing is like many other tests, and we should consider it alongside others and with many of the same lenses. The National Screening Committee has a set of criteria that it uses in various contexts, including, as we've heard, in newborn babies. It's one of the reasons why having a National Screening Committee as part of our NHS steering group, why doing the public consultation, public dialogue we did with them is really crucial, because we think that they and their frameworks are really important in terms of us thinking about the sorts of evidence we need to generate, because those questions that are there in those criteria are many of the questions that we need to explore. They're about the level of confidence of prediction of disease, whether it's by a genome test or whether it's by some other sort of test that's currently used in screening. Many of those questions are very similar. There are some nuances that are a little different, and for example, thinking in some of the specifics about how one selects not just conditions, but also zooms in to the level of detail of particular variants that we might or might not return. We will need to think through with a slightly different lens that is if you like, bespoke for whole genome sequencing. But I think many of those criteria are, relevant and in fact work very well for whole genome sequencing.
Francis, do you wish to add anything to that?
The criteria that the National Screening Committee uses are very clear and very sensible, and they start with looking at the particular condition, what would potentially be the benefit of diagnosing this very early, and they would consider all the questions about our treatments available and so on. And then towards the end of that discussion, they would then say, right, which is the best technology to use in order to diagnose that with particular condition? Whereas I think what might be at risk of happening when we consider whole genome sequencing is we start at the other end of the question and say, we've got this technology, what could it detect? And then move back down the ladder towards thinking about the individual conditions and the justification for screening for them. So my preference would be that we do it the old-fashioned way and consider the risks and benefits of screening for a particular condition from a clinical point of view, and then decide which is the best technology to use to diagnose that particular condition.
One of the really interesting parts of that conversation is one of both the benefits of whole genome sequencing, but also, for example, tandem mass spec, which is the predominant technology that's used in a number of the metabolic disorders, is the benefit, as we've talked about, of potentially diagnosing multiple conditions. And that's where, and it's really interesting talking to people who've worked through and done, thought about the screening committee criteria very carefully over the years, is there is, the part of the benefit here is the potential to, with a single technology, test for multiple conditions, and thereby reducing at least the upfront test component cost that would be attributed to each individual condition down. And so that is part of the benefit, is the fact that it can spread across multiple conditions. And so what we are envisaging in terms of generation of evidence is one needs to do both things. One needs to be, as Francis says, absolutely precise and cautious condition by condition, and take, whether it's the right term, the sort of public health view, to step back and look at the whole system costs at the same time. And it's doing those two things. So I think it's really important. That definitely shouldn't undermine the condition by condition question that one takes, and the caution that one applies condition by condition. And that's one of the reasons that everyone will have picked up from all of us. This is a painstaking process, and one that we need to take our time to do right and think through every detail, not just of the selection of the genes, but also, I think Emma was alluding to it, I think we all have, thinking all the way through the clinical pathway to make sure that we know what, for example, levels of competence people expect through the whole journey that one would be potentially setting up for each of those genes or even variants.
Okay, unless you have anything to add, Emma, I'm going to move on to the next question, which I hope is a quick one. And that's from Rachel Wood, and I think I'll put that to you, Richard. Please, can you clarify whether the pilot of the whole WGS, which is both put the whole genome sequencing of newborns, will be in England only, or are the devolved nations involved at all?
Well, our public dialogue was UK-wide. The National Screening Committee has a UK-wide profile. We're in conversation with all of the nations of the UK, so we're keen that it be UK-wide.
So it's watch this space then, and fingers crossed. Great. Okay, so the next question, it's sort of a comment really, but I think you might want to, it's something that you've touched on and I think it was worthy of discussion, and that's from Sophie Pete, and she says, I've heard a lot of conversation around using whole genome sequencing for newborn screening for treatable conditions. However, there are many rare conditions that are not treatable but are considered actionable, and there are still great benefits in identifying these conditions in newborns. And it sort of tied in with something that came from Will Owen, which is further down, if I can just find it. And he's asked quite a few comments, but he because he commented that even if an effective treatment is not available, there are many benefits to knowing that a baby has a serious condition. Not least among these benefits is the choice to avoid having multiple affected children. This is a major disaster, he says. So I think I'd like the panel, perhaps starting with Emma, to pick up on this question of treatable and actionable, and how you're going to go about navigating that, and the different things and the different importance that different patient groups may put on these things.
I think that kind of comes back to what I was talking about earlier, in that if you're taking a cautious approach initially, you're thinking about things that are treatable in terms of treatable. Have we got something that is going to essentially remove that disease? Are we addressing that underlying pathology? Have we got something that actually does treat, cure that disease in some way? But of course, there are conditions on the newborn screening currently where that isn't the case. So, for example, cystic fibrosis is we screen for cystic fibrosis. There is a treatment that improves the quality of life and the length of life, and the clinical outcomes are better if you start that treatment at a young age, which is why that was considered a valid treatment to include. And so I think we have to be thinking of, I do think as part of this decision-making process, we have to be thinking about those grey areas and those disorders that fit alongside the sorts of disorders we've already been thinking about. So I do think that question is important, but we need to start from that deliberately cautious point of what is treatable, and then work forward from that, carefully considering those principles. I would echo Francis's point about the diagnostic odyssey. I think it's very difficult to think about newborn screening in the terms of reducing diagnostic odysseys, because it is a really tricky time immediately after birth. It's a very precious time immediately after birth. There is a really important bonding process that takes place. And so if we're going to disrupt that in some way, considering all the benefits that have been raised, we need to be being very careful about how we do that, and really taking proper stock of what we're trying to achieve by that.
Francis, do you want to come in now?
I think the question I would ask is, when do we need to know what the diagnosis the child has, given that it's much more difficult to interpret sequence data when a baby is completely asymptomatic? Do we need to know at the age of a few weeks that a baby is going to develop a condition in a few months or a few years' time? Or would it be better to wait until the child becomes symptomatic and then do your whole genome sequencing, at which stage it'll be much easier to analyze the results? You'll have fewer false positive results. And if whole genome sequencing is going to become as widely available in the NHS as we're being told, and if the turnaround times are going to improve to the extent that we hope, then if you know you're going to be able to make a diagnosis with more confidence and reasonably promptly at the time the child begins to start showing symptoms, I think one would really have to consider at which time is it better to have that information. And I suspect for some conditions, it would be both safer and more accurate, and therefore ultimately more useful to wait until the child is symptomatic and do the whole genome sequencing then.
Thank you, Francis. And I'm delighted to say that Charlie Steward has just been able to join us, so he'll be able to join us for some of the questions that I'm going to ask now.
One of the Sarah, if I can just come in on that point.
Sure.
One of the things that we've heard and you see in the chat, and we all recognise, is a real diversity of views. Also, there's a real diversity in terms of preference of language, and about some of the thinking about whether something's a diagnosis when we're talking about treatment, and for example, even within communities with particular conditions, there's quite a lot of diversity of views. And so that's something we're very sensitive to and really keen as part of how we approach this. We have also had quite a useful initial steer from our public dialogue work that overall those views tend towards the cautious interpretation of actionability in terms of intervention for conditions where there's substantial reduction of harm. But that's something that we're really keen to continue to explore.
Great, thanks for that. So I'm going to move on to the next question because we've now got an awful lot of questions, and that is from Jennifer Kundick, and she says, looking at BabySeq in study in the USA, only 7% of parents consented to whole genome sequencing in the pilot study, and would not want whole genome sequencing to reduce participation in the very current and very successful, current newborn screening program. And I wonder, I suppose, if what Genomics England have done to sort of look at that and think about how that may impact and to avoid that those sort of issues in the UK if there's not much pickup.
Happy
so
to
Rich first.
Yeah, happy to start. I think that's one of the things that we're really keen, and we've had a number of discussions about. And I think the sort of first do no harm mantra is relevant in all sorts of regards about when we're thinking about this. That includes to the current newborn screening program. And so as we're thinking about how one might even run a research program, let alone think subsequently, that not disrupting what is a very successful, really well taken up newborn screening program is really important, and we're passionate about that. In terms of uptake and that specifically BabySeq, which had, as you say, a relatively low uptake, again, that's something that as we develop what would be an approach to providing information about the potential to join the research study, how you provide information on that, at what stage, and also what the offer is in terms of what people expect. I think we need to be really sensitive to what people would be comfortable with. The approach taken in BabySeq was quite specific, I think quite a lot broader than we're talking about here, and consent was taken in a very particular way. So I think we're aware, and it's useful to understand what contributed to that, what we're anticipating, and what information we've had from what dialogue we've had currently with the public is that uptake would be much broader, but we need to work that through in the details of, what are these discussions people are going to be having, what information at what stage will they have had, what opportunity to ask questions will they have had, etc. And we need to make sure that we get that balance right, and that it is something that people are comfortable saying yes to, because this will always be an option. It's always going to be a would you like to, rather than something as the same with the newborn screening program. It's always an option for people, not something that's imposed on them.
Charlie, as you've joined us, I wonder whether you wanted to comment on this and perhaps, I don't know, speculate as to why it was such a low take up in that pilot study, coming at it from the sort of patient advocate, the parent with the experience angle.
Well, the BabySeq, so this is the project run by Professor Robert Green, Harvard. Actually, I do know Robert, and for a start, I don't know how the project was funded, so I'm assuming that there was funding for everybody to go on it. But there is, and we see this. We see this. I don't know if you've already mentioned it, but that there is certainly a concern about how genomics is used, or could be used. And I refer you to the example of the Spectrum 10K study that was, I think, being led by Cambridge University, or certainly had an association with Cambridge University, which was looking at autism and genomics. And the study, I think, has caused such an uproar that it has been paused for the time being. And this is mostly due to I believe, and please, if I'm wrong, do tell me, is because not enough PPI, patient involvement, patient engagement, etc., was done to understand what it is that people wanted from the autism study. And I wonder if there's something similar in this sort of project where essentially there's a lot more education that needs to be done to demystify genomics and to make genomics really considered to be much more of a mainstream clinical tool. So perhaps in a couple of years' time, if you were to go back and do the same thing, and I'm thinking, you know, how COVID has sort of made genomics a much more sort of widespread topic to talk about. Very little good news to come out of COVID at all, but I would suggest that, you know, making people more aware of the benefits of things like genomics and looking at things like different variants, whatever. Perhaps when people become a little bit more aware of the benefits and of course the limitations of genomics, then they might be a little bit more inclined to participate in this.
So really important then to involve patients and other stakeholders, carers, parents, etc. So I'm going to move on now to the next question from Julia Rankin. So she says, in the pilot study, it should be relatively straightforward to collect data on the benefits of early diagnosis of treatable genetic disorders, but how would you collect data on the potential harms outlined by Francis Flinter, e.g. false positives, parent-child bonding difficulties, health anxiety, etc. And I'm going to go to Francis first, because I'd like Francis to specify anything else that she'd sort of like to see measured perhaps as those potential harms.
I think Julia summarised the key ones, actually. It's the false positives, the very long period of time that we may need before we even clarify some of those. There may well be also a way of measuring the cost to the NHS in terms of all the additional clinic appointments that will be needed to see and test and evaluate, and hopefully reassure some of those who've had false positives, if it is possible, to do other tests that would indicate that actually they don't have the disease for which they've been conditionally been a label. So some sort of assessment of the impact on the NHS is probably the key other thing I'd add to Julia's list.
So Rich, how are you going to tackle that? Is there going to be some measure to capture that data?
So those, as I mentioned in talking, those are some of the key things that we're really keen to explore, and we're over the next few months in the design phase of what a pilot would look like. We're going to be looking at the exact sort of details of how we'll capture some of those, but perhaps to share some of the thoughts we have and some of our experience to date, and really I think to emphasize why doing this in a research setting, being very clear about that and making sure in the establishment of a research program, one ensures that we are going to be able to answer these questions well. So for example, in terms of sort of long-term impact on the healthcare system, that's something that we've heard really clearly, both in terms of resourcing to enroll people in a program, but also tracking what happens after findings are returned. One of the things that we've done in the 100,000 Genomes Project, and in fact was part of that New England Journal paper and was really useful in that, is that part of the research consent that people agreed to was for us to be able to see their health episodes across the country, and to track what's happening in people who are in the program, and from that get an understanding of what the impact has been. It's not easy, and sometimes, as Francis says, many of these things will take time. When we've looked at the sorts of data that we think we can develop in a sort of relatively short time period, over a period of the first few years of life, that's one of the reasons why focusing on really early onset, highly penetrant, high confidence conditions is both the right thing to do from the perspective of what we're hearing people would potentially like to hear about, but it also focuses in on conditions where those questions are easiest to answer.
Okay, because we've got so many questions, unless anyone's burning to say anything in addition, I'm going to move on to the next one. And I'm going to go to David Curtis, who says, if one has a list of actionable genes variants, which one would screen asymptomatic babies for, why not do targeted testing instead of whole genome sequencing? So who wants to go with that one first? Rich or Emma?
I can do that if you like.
Yeah, Emma.
So I think one of the real values of whole genome sequencing is first of all its cost effectiveness. So it can actually be more cost effective nowadays even if you're looking at a single gene to do a test like a whole genome sequence. Targeted testing is not that straightforward. It's not that cost effective. Having a whole genome sequencing, as I said, also gives you the ability to include new genes as things go along. It's an extremely flexible platform. So I guess those would be my main answers to that. I don't know if you want to add any more to that, Rich.
No, I think that's right, and it's that flexibility and the reality of as you say, panels are something which are less and less used because of some of the technical challenges of establishing, validating, revalidating. That's a really key advantage.
Francis, do you want to come in on this one?
No, I was just thinking about the example we had from 2 weeks ago, SMA, which is the most powerful case I've heard made for a condition to be added to the list. And they explained very clearly then that the best test for picking that up is not whole genome sequencing. It's a targeted test to look for the deletion in the SMN gene. I guess my caution is that we're slipping back to the being driven by the technology and what we can do with it, rather than the more conventional way round of looking at things. And the other thing that we perhaps need to add to Julia's list in terms of assessing the costs is that I presume with conditions that screen positive on whole genome sequencing, there will still subsequently need to be some sort of confirmatory Sanger sequencing or whatever is required to confirm that that is a genuine finding before it gets reported. So we need to think very carefully about the additional costs of completing the analysis before results can get fed back to parents.
Yeah, that's an important point. So the next question is from an anonymous attendee. Are you liaising with the Human Fertilization and Embryology Authority, who do, well, they have a list of conditions that is allowed to be used for pre-implantation genetic testing?
So I think one thing perhaps to emphasize is that we've been quite clear that the scope of what we're exploring here is in terms of the newborn period and not prenatal, not testing during pregnancy. So we think that's it's an area with lots of sort of quite distinct questions, and that's one of the things we're really keen to be absolutely clear about. We are working really closely with midwives, with the Royal College of Obstetrics and Gynecology, who are represented on our NHS steering group, and so that same knowledge set and many of the same experts will be feeding into how we work through this. Francis,
as someone who worked in PGD for many years, have you got anything to come in on that?
Well, the Human Fertilization and Embryology Authority has a list of conditions for which licenses have been granted allowing PGD, but that's a fairly limited list because it's only conditions where people have come forward requesting pre-implantation genetic diagnosis. So it serves a very different purpose. So I don't think that list would necessarily be helpful for the newborn screening project, because some of the conditions on that list do not present in the neonatal period or early childhood.
Okay, I'm going to go next to a question from Jim Bonham, which is: the real question is whether genomic analysis is warranted in asymptomatic children without any evidence of disease. One might reasonably imagine that any changes in the genome in well children would be far less easy to have significance for the child. Francis, do you want to come in first on that one?
He's absolutely right. Just because we find an alteration in the DNA of an asymptomatic child, we can't necessarily conclude, we won't necessarily know whether or not it has any significance for them. If you're if you're testing a child with symptoms that affect a particular organ and you find an alteration in a gene which has an important role in that organ, you can see how you begin to build up the jigsaw puzzle and you can put 2 and 2 together. Whereas if you find an alteration in a gene in a completely asymptomatic child, it can be much more difficult to work out what the significance of that might be.
I suppose, and then it's how much time and resources put into trying to get to the bottom of that would be part of that. Charlie, do you want to come in on this one?
Well, yes, I completely agree with Francis. Although I would say that, you know, if you, and this, I'm speaking purely as a parent here, please. Now, if you were to find a variant in a gene, perhaps that was known to be in a type of leukodystrophy, which we know perhaps a later onset, then you might be able to monitor that child, or you might be able to then consider, while that child is growing up, to have extra monitoring. I don't know whether that's allowed in clinical practice or not, but I do foresee some way of, at least perhaps in a select set of genes that are known to be later onset, then perhaps it might be possible to follow this child more closely. Apologies if that's completely against clinical practice.
Emma, do you want to come in, or should we move on to the next question?
Entirely up to you, Sarah. I was only going to add that I think what Francis has said is absolutely true, but I would balance that with there are of course variant genes that we can interpret, and so it's perhaps a little bit disingenuous to say that it's always difficult to interpret genes in asymptomatic children. There are some genes in which it is not difficult to interpret variants. There are some variants which are not difficult to interpret.
No, I accept that. That's correct.
And that's what I think we need to be thinking. I mean, and that is for me an absolutely fundamentally important thing to be considering within the pilot of this. What that element of it is absolutely important.
So the next question I'm going to go for is from Jess Buxton. Will whole genome sequencing of pilot participants, which will detect SNVs and small indels, be complemented by another technology to pick up larger structural variants? And so I think we'll go perhaps to Rich first with that. And if it's part of your answer, Rich, for people who aren't familiar with those terms, if you could just sort of quickly spell them out in your answer, that would be great.
So this is a question, I think, about the different sorts of variation in the genome that current whole genome sequencing technologies can detect, and some are better and worse at. So at the moment, we know that the predominant technology for whole genome sequencing, which is short read whole genome sequencing, is less good at the particular type of variant that Jess highlighted, at certain structural variants. One of the things we're discussing at the moment, and will be over the coming months and longer, is what are the different questions we're exploring in this pilot. That last discussion we had about the confidence of interpreting variants is one. It's why we need a pilot to explore exactly these questions with a really critical eye. The second is on areas of the exact technology that we use, the exact way we use it, the exact way we run the computer algorithms that interpret the data. And it may be that within the pilot, it's right to try a number of different approaches to develop data that can help inform future decisions. So we have an open mind on that at the moment. And I think it's a really interesting question that we should be exploring.
So this one is from an anonymous attendee who says, of course, there will soon be companies that offer whole genome sequencing, so parents will be able to get their children's sequencing, as and when, if they have the funds, and this could cause inequality, and the data analysis may be inadequate. So how will this be managed? And I suppose I'd sort of expand the question to say that if this is rolled out as a pilot, then other people who can't access it for whatever reason are going to want it, because people are always a bit like that. And I suppose this could potentially, I hadn't even thought of this as an issue, cause a problem for the NHS. Is this something that Genomics England have thought about yet, or is this, and how will you tackle that? So go to Rich first.
Yeah, it is something that we've thought about and been aware of, and actually some of the early discussions we've had with experts across the country and patient groups is this question of the anxiety that if evidence isn't developed in a really structured and thoughtful and well-powered way, and standards aren't established, we know that this sort of thing will start becoming available in a less well-evidenced way. One of the really important things about a pilot could be to set that standard, develop the evidence, develop the expectations, so that if there were private offerings, that we could be really clear on what the standards are that we should expect. I guess, and that question of equity of access, we've also been thinking about within our work, as we do across all of our work at Genomics England, and the NHS is passionate about, and I think it's one of the great strengths of UK healthcare. It's not easy to deliver. It's easy to talk about it. It's not easy to deliver. And one of the things that we will be thinking about really hard as we develop the shape of a pilot is thinking about that from multiple lenses, thinking about that in terms of people being able to understand and access information to decide if they wanted to join the pilot. People, once they've joined a pilot, knowing that, Francis alluded to this, that if they're from a community who's less well represented in historical genomic data sets, we're doing everything we can to make sure that we can offer a similar chance of identifying conditions as we can to other communities. So that's one of the themes that will be running all the way through our thinking in this. I think it's really important, and it's a battle I don't think that ever ends. It's one that we have to really have at the forefront of our mind throughout.
Can I make a
Francis,
comment?
yes.
So the Science and Technology Committee published a report earlier this year about direct-to-consumer genetic testing, and made a number of rather quite strong recommendations about the need for regulation, and looked specifically at the issue about parents requesting over-the-counter genetic testing from a commercial company on their children, and finding out information which we would not normally reckon to try and find out until the child themselves was an adult and capable of making a decision themselves as whether or not they wished to know that. The government's response to that has been to say that they have asked the MHRA, which is the regulator, to review this whole area and come up with a set of recommendations. And the MHRA is currently out to consultation, or the consultation may have just closed. I don't remember the exact date.
It's still open.
It is still open. Oh, well, people might like to have a look at that. So I think we may well wish to take a look at that and make suggestions as to how we can find ways of protecting children from having information about their genomic future disclosed to their parents and established before they are of an age to decide whether or not they wish to know that themselves. Of course, that's talking more about things that will affect them later on in life, not things that could have significance in early childhood, which is the focus of the discussion today. But nevertheless, these sorts of tests are becoming available commercially, and we do need to think about the impact of that, because if people can't get what they want from the NHS, they may well turn to alternative providers.
Absolutely, we see that everywhere. So I'm going to, in the interest of time, move on to another question. This one's from Carmel Turner. Has the insurance industry been part of the discussions around the this issue and the pilot in this country or in others?
There haven't been discussions with insurance companies, and one, as you've alluded to, questions about insurance company access is one that is long running in genomics, and there are very clear red lines for the public that we respect and will continue to respect. It's been something that we've engaged with in some of our previous public dialogue work on the use of genomics in healthcare, and I think we're very sort of firmly in line with the public opinion on that, in that this is very clearly about diagnosis, identifying conditions for healthcare use, and ensure access to this data isn't something that the public would in any way find acceptable.
And there's a comment from Peter Brodie. However much you might like to limit the test or diagnosis to the baby, a genome examination on a child has an impact on other children and the extended family. And I suppose it's important to think about how that will be addressed in this pilot. I don't know whether anyone wants to add to Peter's comment, or whether we take that as read and move on.
I think that's part. Emma alluded to it in her talk, thinking about who the benefit is for, but also who might be affected. So I think really to agree with Peter, but also to sort of emphasise that is part of the discussion that we'll be having as one thinks through condition by condition. One has to think about all of those things as well.
This is from an anonymous attendee. What about a disease like long QT that often doesn't manifest until early adulthood, sort of 20s, and can cause sudden death, but can be helped by implanted defibrillator? So how would that fit into your sort of schematic for deciding what was on the list, Emma? Perhaps I'll go to you first.
Yeah, so I think that is one of those conditions that falls into all of the difficult categories I was talking about. The genes are genes in which it's very difficult to interpret variants. The what we call penetrance, the number of patients who necessarily manifest the disease if they carry the disease variant, is it's variable. There's variable age of onset, and there's variability around the treatments. So it is one of those disorders that absolutely typifies some of the questions that we need to be asking, but from my perspective in the pilot falls outside of a number of the different things we would be thinking about in terms of where we should be drawing that line, that bar of cautiousness initially.
Okay, I'm going to do one final question looking at the time, and that's from Catherine Morley. Do the panel believe that the data should be reanalyzed and re-reported when new major breakthroughs are made in research, e.g. if a variant is upgraded from unknown significance / benign to definitely pathogenic? So I suppose that's how you're going to manage this going forward. So perhaps, Rich, you could answer that one.
Yeah, I think that's one of the real potential values of the way genome data is available and the way it can be used. One of the things I think we definitely will be keen to explore both attitudes to and sort of practical, the practical reality of is how one would do that, thinking about what that would mean in terms of messages and expectations for families, but also in terms of sort of the reality in the NHS of potentially additional information coming later, is something that we've heard from the public that they see as a real value here, and we'll need to work through how that would work in reality.